Good morning. I would like to thank Mr. Patakos, Dr. Sparias, for the opportunity to speak about one of my special interests in interventional cardiology, cardiogenic shock, and in particular, I will talk about TAVI in cardiogenic shock. There are two concepts that I want to emphasize about cardiogenic shock. The first concept is that it's not just a pump failure. It starts as a pump failure, but it evolves in something more. After the initial cardiac injury, we have a metabolic process, so we have mechanisms of vasoconstriction, ischemia, fluid overload, and inflammation. And why this is important for our patient? This is important because the deeper that we get into this process, the most difficult it is to help our patient. And even if we correct the problem with the pump, it doesn't mean that we're going to save the patient. The other concept has to do with the fact that cardiogenic shock is not a binary situation. We use a binary definition in clinical studies, but in real life, cardiogenic shock is a non-binary dynamic condition that could evolve from a pre-shock condition to an extremis where we have circulatory collapse. Aortic stenosis is one of the multiple causes of cardiogenic shock. It's not the commonest one. As you can see in our data from Matikon University Hospital, it happened in 6% of our cardiogenic shock patients, and this is the number in different studies between 2 and 7. But it's an important cause, as it will be lethal, and secondly, as there's a way to fix the problem. There's a way to fix aortic stenosis, to correct it, and here comes the question whether we should do it with TAVI in these patients. This is the summary of the studies looking on TAVI in cardiogenic shock patients. Obviously, I'm not going to talk about all the studies. I just want to emphasize three things. First of all, the study shows that it is not only feasible, but in selected patients, this approach, performing TAVI, is an effective one. However, the second comment is that all the studies are observational and almost all of them retrospective. And the third is that most of the studies involve very small numbers. The only exclusion in a contemporary cohort is the data from the STS registry, STS-ACC registry with the SAPIEN valve, where patients with, that they were coded as cardiogenic shock in this registry were compared with patients that did not have cardiogenic shock. And as you can see in the Kaplan-Meier curves, after an initial difference in mortality after 30 days was the same. Even if we look mortality within 30 days, it was quite low for the patient with cardiogenic shock at almost 13%. However, we have to interpret this data carefully, mainly because it looks like that the most critically ill patients were not included in the registry. As we see, the definition of shock did not involve hemodynamic assessment or lactate, things that are necessary in order to say that the patient has shock. And if we look at some baseline characteristics like the age, the ejection fraction, the mean ejection fraction was around 40%, or the ICU stay, we will understand that this cohort was not that ill. In order to have, let's say, a more pragmatic understanding of what happens to these patients, I will show you this study from Munich, a busy TAVI center, where patients that they were critically ill with cardiogenic shock were compared with patients with heart failure, but not cardiogenic shock, and patients that they came in electively. And as you can see in the Kaplan-Meier curves, cardiogenic shock patients had a much higher mortality that reached up to 40% in the first few weeks, the first couple of months. Importantly, though, the same results as the STS registry, after the initial period of time, the prognosis for all these cohorts was the same, which means that patients that they were selected well or they were self-selected after the initial hit of cardiogenic shock, they had a good prognosis. So the summary of the studies is that not only feasible, but effective in selected patients. What happened with balloon valvuloplasty? That used to be our approach when we didn't have TAVI. We know, and this is nicely shown by this data from Cleveland Clinic, that balloon valvuloplasty does not long. After the first 30 days, in the patient's cardiogenic shock, mortality is the same with the patients treated medically. However, and this is something that was discussed with Professor Kilic last year, balloon valvuloplasty may be used as a bridge to TAVI. We have reasons to do it. It's an easier procedure, it's a cheaper procedure, and it's more available. What happened with what is the role of mechanical circulatory support? I cannot say that there is a clear role. What is published is case reports or small series. And even if we see the series from Henry Ford Hospital in Detroit, you see that even when they used Impella in the cardiogenic shock patients, mortality was as high as 45%. When we are thinking of doing a TAVI in a cardiogenic shock patient, we need to take into account practical considerations. Most importantly, the timing of the procedure. Are we going to do it urgently? Are we going to stabilize the patient and do it afterwards? Are we going to use BAV as a bridge? Secondly, the valve that we're going to use, that I think the best advice is to use the one that you are more familiar with. Transfemoral access is the access to go, and I just talk about mechanical circulatory support. Another important thing that we have always to keep in mind is that TAVI is the safe and effective procedure that it is nowadays because of very careful planning. So CT is critical in contemporary TAVI, and we have to think if we can do a CT in these patients or think alternatives as a TOE. Going towards the end of my presentation, and these are two algorithms of how to deal with these patients from European Societies of Heart Failure, but also EAPCI. TAVI is part of these algorithms. We have to assess the patients, and if we think that it is worth doing it, to do it. I want to emphasize, and I have put a circle around it, the approach on the left-hand side of the screen, that after the initial support measures, we check about futility, and then a heart team or a shock team, if you want, decides about performing the TAVI. And this is going to be my last slide, emphasizing this approach. Once more, I will say that TAVI is feasible and it is effective in selected patients. So the main question is who are the patients that are going to benefit, and who are the patients that the procedure is going to be futile to perform. And this is the difficult question for us. I would like to thank you for your attention.
So I propose to hear the next piece, and then we can move for discussion after the cardiac session. The next